So we can start. Assalamu
Sure, yes.
alaikum. So this is going to be my last lecture topic with you for this block. So the next time you hear from me, it's going to be in the head and neck and special senses. So today we're going to discuss encephalitis. And by the end of today's discussion, what is expected of you? You should be able to discuss some viral etiological agents of encephalitis in terms of their epidemiology, who are the people affected, the pathogenesis and the biology of the viral agent, the clinical presentation, how you make a diagnosis, and guideline management. So what we are going to do is we are going to select some common agents of encephalitis and discuss them. We can't discuss everything, okay? So as a form of introduction, the condition encephalitis refers to diffuse inflammation of the brain parenchyma, usually due to infection with a virus. We can classify the condition into basically two broad groups. You have the primary and the post-infection. The primary encephalitis occurs as a direct result of infection. So you have the viral agent actively replicating in the neurons. Then there's a response. There's an inflammatory response to that process. Most of the time, you are able to isolate the viral agent with primary encephalitis. With post-infection, the exact mechanism of disease is not well known, but the hypothesis is that it's likely to be autoimmune. So this condition arises following vaccination or a viral infection that was subclinical. Most of the time, the patient will not recall that he or she had some form of mild viral infection. In this form of encephalitis, the neurons are spared and the virus is not usually recovered from clinical specimen. A severe form of this condition is termed acute disseminated encephalomyelitis, ADEM, which is more common in adolescents and children than in adults. Now, in most cases of encephalitis, the causative infectious agent may not be identified. However, in situations where we do identify a pathogen, viral agents are the leading cause of this condition. So if an agent is identified in the United States, these three viral agents are the leading agents of infection. However, let me quickly add that herpes simplex virus and enteroviruses can cause global infection. So you can have them in other countries other than the US. Although we say that these three agents are the leading cause of encephalitis, there are other viruses that could cause encephalitis, including other herpes viruses. Things like cytomegalovirus, Epstein-Barr virus, and the viral agent of chickenpox, varicella zoster virus. Arboviruses, which are so named because they are arthropod-borne, may also cause encephalitis. For example, you have the Eastern equine, Western equine, St. Louis encephalitis, Japanese bee encephalitis. These are all examples of arboviruses that are associated with encephalitis in humans. Other viral agents such as measles, mumps, rubella, rabies, and HIV may also cause encephalitis as part of the disease spectrum. So we've stated that viral agents are the leading cause of encephalitis. That's the most important message you should remember from today's lecture. However, there are other microbial agents that are non-viral that could cause encephalitis, albeit they are not as frequent as viral agents. These include bacterial agents such as Borrelia, Bacterferi, the agent of relapsing fever, Coxiella bonnetii, the agent of Q fever, Rickettsia rickettsii, that cause rickettsiosis in humans, Ehrlichia, Listeria, Mycobacterium tuberculosis. Now, do you need to memorize these names? The answer is no. But it will be good to recall that apart from viruses, bacteria, parasites, and fungal agents can cause encephalitis. So from this table, what do I want you to note? The spectrum of microbial agents. I don't expect you to memorize anything other than the fact that different agents with viral agents as the leading cause may result in encephalitis. Now, in terms of presentation, encephalitis as well as meningitis may coexist together. You may have a situation in which one clinical presentation predominates. So the patient may present with features highly suggestive of meningitis, such as fever, neck stiffness, and what other signs of meningitis do you know? Headache. Or the patient may present with features of encephalitis, in which you have fever, you have headache, neck stiffness is not so prominent. You may have a change in character, or you may have a change in behavior of the patient. These are features of encephalitis more than meningitis. At times, you may have features of both conditions. So in that case, you say that the patient has meningoencephalitis. What makes a patient likely to come down with this condition? So we are talking about the predisposing factors. The first one is an immunocompromised patient. Immunocompromised may be from infection with HIV, or the patient has gone into the AIDS stage of the disease, or it could be as a result of the patient being on immunosuppressive therapy following an organ transplant. So any condition that could lead a patient to being immunocompromised predispose the patient to encephalitis. The agents that are usually associated with this subset of patients include parasitic agents like Toxoplasma gondii, fungal agents such as Coccidioides, Cryptococcus, Histoplasma, viral agents such as cytomegalovirus, CMV, and bacterial agents such as Mycobacterium tuberculosis. These are particularly important in this subset of patients that come down with encephalitis. In normal patients who are not immune compromised, a visit to endemic areas, whether on business, whether as a tourist, for whatever reason, could be a risk factor. You have arthropods that transmit this virus thriving in endemic areas. So if you travel to these areas and you don't take adequate precaution to prevent exposure to these arthropod vectors, you may end up having transmission of this viral agent. It could also be transmitted through an animal bite, particularly from rabies. Rabies virus is by the rabid animal. It could be a dog, could be a raccoon, okay? So that could lead to rabies encephalitis. Another predisposing factor is working outdoors. So you are a logger, you are a botanist and you're always characterizing plants and things like that. So you're always working outdoors where you have an increased chance of coming into contact with the arthropod vectors, be it mosquito or tick, that could transmit the viral agent. In terms of pathogenesis, remember we said we can have two forms of encephalitis. We can have primary and the post-infection. So in the primary infectious encephalitis, the cause of disease is inflammation of the brain parenchyma caused by direct infection with viruses or other microbial agents. So you have the active replication of the virus with an inflammatory response from the human host. In post-infectious encephalitis, the mechanism of disease is believed to be autoimmune, following a preceding viral infection. So let's look at specific agents and specific conditions. First, we'll start with herpes simplex virus encephalitis because this is the most common agent of encephalitis. It is also referred to as human herpes virus. So you may find in some journals or textbooks, the agent is referred to as herpes simplex virus or as human herpes virus. It's still the same agent. There are two types. You have the herpes simplex virus type 1 and the herpes simplex virus type 2. These two viruses have predilection for specific sites. Herpes simplex type 1 tends to cause oral facial lesions, while herpes simplex type 2 tends to cause genital lesions. Herpes viruses, as a rule, exhibit what we call latency. Depending on the particular virus that you're dealing with, the latency occurs in specific tissues. For example, with the herpes simplex viruses, latency is in neural tissues. As a result, infection is lifelong. However, for an agent such as cytomegalovirus, latency is in glandular tissues. So you can have these organisms hiding in the salivary glands or in the kidneys. Okay, so depending on the particular herpes virus that you're dealing with, the latency is tissue specific. The herpes virus has a worldwide occurrence. It is most prevalent among children in lower socioeconomic groups who live in crowded environments because this allows easy transmission of this organism, of this agent. You know, in such settings, you're likely to have shared feeding utensils, which can transmit the agent to an uninfected host. Body fluids such as saliva, urine may be potential sources of infections. Other things like stool, active skin lesions, or when you have eye discharge, these are also sources of the infectious agent from one person to another. In terms of the biology of this virus, herpes simplex virus are large, enveloped, double-stranded DNA viruses. You know what that means? Enveloped means that they have some form of lipid covering, usually derived from the host cell. Double-stranded means you have two strands and it's a DNA virus. There could be asymptomatic shedding of the virus, and it is the most common cause of acute, sporadic, focal encephalitis. With herpes simplex virus type 1, like I stated earlier, it tends to cause orofacial infection. Lesions are usually perioral or intraoral. It is the causative agent of acute encephalitis, which is usually focal after the neonatal period. It typically affects adults with a slight male preponderance. Herpes simplex type 2 causes genital infection, and it's the causative agent of encephalitis, usually diffuse in the newborn. Now, with herpes simplex type 1 encephalitis, the initial orificial infection may be asymptomatic. Then the virus replicates in the skin, infecting nerve fibers ending, and it is transported in a retrograde fashion, and it becomes dormant within the neurons. So this could be the olfactory or trigeminal ganglia neurons. Reactivation may occur during times of stress, fever, or acute illness, and the reactivated virus may now spread proximally to the brain, causing focal encephalitis, predominantly affecting the temporal lobe if the reactivated virus is coming from the trigeminal ganglia. Or you may have the inferior frontal lobe affected if the reactivated virus is coming from the olfactory ganglia. With herpes simplex type 2, as opposed to type 1, you now have a diffuse meningoencephalitis. The neonate acquires such a primary infection from the mother's genital tract, and the initial clinical features are similar to those of aseptic meningitis caused by other viruses. You still recall the clinical features of meningitis in the newborn, in the young children. Remember, I told you that you have non-specific symptoms. Patient may be irritable, the mother may tell you the baby is not feeding well, things like that. So the initial clinical features are similar to those of aseptic meningitis. If you collect the CSF and you analyze it, it shows a pleocytosis, that is, you have an elevated white cell count. Again, I don't expect you to memorize values, okay? I'm okay if you tell me that you have elevated white cell count. That's all I need to know. Unlike what we have with meningitis, you may have red blood cells as well present in the CSF. The CSF protein concentration is usually elevated, slight elevation, and the glucose level is normal. The identification of the organism in the CSF may be achieved using nucleic acid amplification assays, such as PCR. As a result, you don't need to send the biopsy sample to the histology lab again. So in terms of presentation, the patient may present with altered level of consciousness, change in personality, or a seizure. Other effects may include smell and taste hallucination. Some patients may tell you, I think the house is on fire, something is burning, when there's nothing burning. So this may be a sign, or a symptom rather. There could be neurological abnormalities, such as aphasia. Now, you can see from the list of possible symptoms that the patient may come in, that there is no neck stiffness. There may or may not be fever, okay? So these are things that will help you to sort of make up your mind clinically, what am I dealing with? In terms of diagnosis and management, there are different approaches to diagnosis. You may, if you have the facility, go ahead to perform a viral culture. If that is not available, serologic may be used, and what you are interested in when you send in serum is to demonstrate a rising antibody titer between the convalescent and acute serum. So that presupposes that the patient presented early in the disease process and then you followed the patient up. But most of the time, you may not get the patient at the acute stage. Histology is another approach to diagnosis, but with the advent of nucleic acid amplification techniques, you may not need to do this. We move on to another group of viruses, apart from the herpes viruses. These are called arboviruses, and from the name, you have an idea of how they are transmitted. The name is actually to suggest that they are arthropod borne. So it's just an abbreviation of arthropod that we turn to arbo. So arboviruses are arthropod borne. Three major manifestations of arboviral diseases in humans associated with different tropism of various viruses for human organs. So the arboviruses is a large group of viruses that tend to cause different clinical presentations when they infect humans. Some of them have a predilection for the central nervous system. So they can lead to aseptic meningitis or meningoencephalitis. Some arboviruses cause severe inflammation of the brain. That is, they cause encephalitis with damage or destruction of neural cells that may be fatal or can lead to permanent neurological damage in survivors. Now, apart from those arboviruses that have a predilection for the CNS, some of them have involvement of major organ systems in the body, with particular damage to the liver, as occurs with yellow fever. So in this case, the yellow fever virus destroys the liver. It doesn't really aim for the CNS. The third syndrome that is associated with arboviruses is a hemorrhagic fever, in which the damage is particularly severe to small blood vessels. So the patient presents with bleeding into the skin, intestines, and other body sites. A good example is a dengue fever virus. So this is just giving you an idea of how arboviruses are quite extensive in the pathology they can cause in the human host. So we are going to focus on those arboviruses that have a predilection for the CNS for the purpose of this discussion. So we have what we call the arbovirus transmission cycle. The usual thing in nature is to have transmission between the arthropod vector and other vertebrate reservoir hosts other than humans. So the usual cycle involves wild birds. However, when humans encroach into areas where you have the arthropod vector, for example, in this case, a mosquito vector, mosquitoes can also feed on humans. And if, unfortunately, they have fed on an infected bird before feeding on the human host, they may end up transmitting the virus to human host or other vertebral hosts, such as horses. So arbovirus transmission cycle typically occurs between the vertebrate reservoir host, in this case, the wild bird, and then the vector. In this example, it's a mosquito. We can also have tick-borne viral agents. The infected vector can also bite other hosts, such as humans and horses, which are regarded as dead-end hosts because the level of viremia in these hosts is too low to provide the vector with an infectious dose. Okay, but although the level of viremia is low, the virus can still wreak havoc in the central nervous system of the human host. So let's look at specific arboviral agents, starting with the Eastern equine encephalitis virus. It is responsible for the most severe infection out of all the encephalitis virus. It is transmitted through the bite of Culiseta swamp mosquito and probably mosquitoes of the Aedes species. And this is what the insect vector looks like. Wild birds are the natural reservoir. Human and horses are dead-end hosts. The disease does not occur during the winter months because mosquitoes are not actively feeding. Outbreaks may, however, occur during the summer months. In terms of presentation, oh, that should be severe. So you can have acute onset of severe headache. Patients may have nausea, vomiting, fever, alteration in mental status. Patient may be confused. For example, they don't know the way to their house again. Or patient may be stuporous. That is, it's difficult to wake them up, like they are so sleepy. There may be neck stiffness, particularly when you have a meningoencephalitis presentation. There could be seizures, or the patient may come in coma. In terms of diagnosis, the approach is to try and isolate the virus through culture if you have the facilities. Serology may also assist. Again, you want to demonstrate a fourfold increase in titer, antibody titer between the acute and convalescent serum. So this presupposes, like I said the last time, that you saw the patient early in the disease process. So you have both the acute serum and the follow-up convalescent serum to compare with. Unfortunately, unlike the herpes viral agents, which could be treated with a cyclovar, and the reason why I'm not going into drug therapy is because I believe you're going to have this in pharmacology, okay? So I don't want to go into that. So in terms of the treatment, unlike herpes simplex, which can be managed with a cyclovar, the arthropod-borne viral agents do not have any drugs that can effectively manage the patient. And there are no vaccines. So the best approach is to prevent contact between a susceptible human host and the insect vector. So if you're walking outdoors, you must make sure that you wear long pants. You prevent, your pants may be, how do you say it, sprayed with insect, okay? And if you've been to areas where you know that the insect vector is endemic, you should take precautions to prevent and things like that. Another agent of significance is Western equine encephalitis. So this is transmitted by the Culex species, particularly Culex tarsalis. Again, humans and horses represent dead-end hosts or blind-end hosts. Both are susceptible to infection and illness, and it commonly manifests as encephalitis. The clinical picture of Western equine encephalitis viral infection is similar to that of the Eastern equine encephalitis virus, but it tends to be a relatively mild condition. And with patients who recover, there is usually little to no neurological sequelae. In terms of diagnosing, again, the approach is if you can isolate the virus, go ahead and do that, or you perform a serology to demonstrate a rising antibody titer level. Just like with the Eastern equine encephalitis virus, there is no effective antiviral therapy, and there are no human vaccines. In horses, there are vaccines available, but for humans, there are no vaccines available. Again, the best thing is to prevent contact between susceptible. We move on to the West Nile virus. The most common cause, invasive arboviral disease in the United States. West Nile virus is a flavivirus. Wild birds are the main reservoir of this viral agent and commonly found in human, birds, and other vertebrates in Africa, West Asia, and the Middle East. So it's found majorly in tropical to subtropical regions of the world. It is transmitted by mosquitoes, especially the Culex species. Transmission may also be achieved through the transplantation of solid organs. Humans are dead-end hosts. In temperate areas, West Nile encephalitis occurs mainly in the late summer or early fall, because that's when the insect vector is actively feeding. In southern climates, this is referring to the US. In southern climates with milder temperature, West Nile encephalitis can occur year-round. Encephalitis occurs in about 1% of infection. Fever and headache without other symptoms of encephalitis may occur in about 20% of patients who are infected. So the main complaint is just fever and headache. The patient has no smell or auditory hallucinations, okay? The patient is not stuporous and things like that. Approximately 80% of infections are asymptomatic, so no fever, no headache. All people or persons living in endemic areas carry a risk of contracting this viral agent, but persons older than age 50 or those with compromised immune system are at particular risk. Severe infection present with symptoms such as headache, high fever, neck stiffness, particularly when it's becoming a meningoencephalitis, stupor, disorientation, coma, tremors, and occasionally you may have patient presenting with seizure disorders. There could be paralysis, and rarely the coma may lead to death. In terms of diagnosis, isolation of the virus from brain tissue may be performed if you have the facilities. Other samples that could help in isolation of the virus include blood and cerebrospinal fluid. You can also detect antibodies in the spinal fluid or blood. Polymerase chain reaction-based assays may also be deployed to achieve a diagnosis. Just like with the other agents we've discussed, other than herpes simplex, there is no antiviral therapy or vaccine available for human infection. Prevention of blood-borne transmission warrants blood banks screen donated blood for the presence of West Nile virus using nucleic acid probes specific for the virus. Any questions? Questions? Which one has latency in neural? Okay, what is the example of working outdoors? Okay, people who are involved in the lumber industry, so loggers, people who cut down trees, okay, in the wild, and that's the people who are involved in the lumbering business. That's an example. Another example is botanists who are looking at plant species and they are trying to characterize them. They go out into the environment to study these plants. So that's another risk group, okay? Tourists, when you go on tourist visit to different areas and you are camping outside, you're not lodged in an hotel, that's another example of being outdoors. Another question says, which one has latency in neural tissue? That is Herpes Simplex viruses. Okay? Cytomegalovirus is another example of herpes virus. Herpes virus is a large group of viruses, okay? It includes the Herpes Simplex virus, it includes cytomegalovirus, it includes varicella zoster virus, it includes Epstein-Barr virus, human Kaposi sarcoma virus. These are all examples of herpes viruses. But when we say herpes simplex virus or human herpes virus, then we are being specific to a subgroup of the herpes virus. With herpes simplex, they have a predilection for neural tissues. And with cytomegalovirus, they have a predilection for glandular tissues. So that was the example I gave. I hope that is clear. Now, between what and what, check the serology. Okay, serology to help you in diagnosis in this case means you saw the patient at the onset of the disease process. You know, it takes time for the body to produce antibodies, right? So the first contact with the virus, when you saw the patient, that is if the patient came to you, you took the serum sample, you assess the titer value, the antibody titer value. Then the patient had overt disease and then the patient is feeling better. You now collect the serum sample again. That's the one we refer to as the convalescent sample. And you look at the value of the antibody. Because you now have a robust response to the virus, the titer value is going to be elevated. Now, the usual thing is that you have a fourfold, okay? So if you have like a 1 unit at the acute phase, and the convalescent is giving you like 8 units, that's already more than fourfold. So that is diagnostic. So the body actually reacted to that viral agent by producing antibody. So that can confirm your diagnosis. Increase in antibody titer between the acute and convalescent serum, yes. Fourfold increase, not just increase. Usually we say fourfold increase. What is sequelae? Sequelae is like complications, what resulted after the infection. Okay, usually a negative result. So that's like a complication. I hope that is clear now. From the arbovirus transmission cycle, the vector should infect the reservoir host before infecting the dead end host. Yes, the reservoir host, just like the name suggests, and if you still recall from the POD lectures on in pathology, in parasitology, you know, I told you that the reservoir host will keep the organism viable and in a transmissible state. So in the reservoir host, which are usually wild birds, the virus can replicate without causing infection, without causing overt clinical symptoms in the wild birds. enough viral particles are produced in the reservoir host such that when the insect vector comes for a blood meal, it takes enough viral particles to be infective to the dead-end host. The dead-end host, unlike the reservoir host, does not allow the virus to replicate to such a level that an uninfected insect vector coming for a blood meal will end up being infected. Is that clear? Is that clear? Any other questions? I hope I've answered all the questions in the chat box. Okay, just a minute. Is it possible to differentiate between encephalitis and meningitis in terms of symptoms only? I'll say no. The reason is this. When we discuss symptoms, signs during lectures, we give you the textbook stuff, which are the common presentations, okay? When you start practicing, you may see presentations that are a little bit not in keeping with what you were taught in the lectures. You know, I tell students that these agents don't read our textbooks, okay? So that's why we always have in journals, people will give you case report. You know, you have atypical presentation of so agent and things like that. So it's not enough because you just don't know how a patient may present. However, what is in the textbook is what happens in a significant population of patients. So if you find a patient coming in with fever, headache, and on clinical examination, there's no significant evidence of meningeal irritation, you may want to look at it as a case of encephalitis. Okay? But if the patient came, the patient has fever, headache, neck stiffness, seizures, obviously the meninges are involved. So you have a, you know, based on clinical grounds, you have a higher tendency, higher likelihood to tend towards meningitis, okay? But you may have a patient with meningitis coming to you without evidence of neck stiffness, and it is still meningitis. So you're not too sure, okay? Until you perform other investigations that could help you to make up your mind. Is that clear? Gather. So is it the bird or the mosquito that is the reservoir? Yes, the bird is the reservoir host. The mosquito is the vector. Okay, if you go back, let's go back to the diagram. Yeah, so look at it. This is the reservoir host. They allow the virus to replicate to a very high level without coming down with infection. So when the insect comes, that's why you have this arrow coming here. The vector feeds on this insect. So in terms of viral transmission, the virus gets into the vector host, okay? Now the vector host, usually if humans don't encroach into the area where you have this interaction between wild birds and the insect vector, it's okay, this cycle is complete. The vector will feed on another wild host, a wild bird host, and then the process continues. However, when we now find our way, you can see that's why you have a branching arrow, because this is not the usual thing. So when we encroach into the habitat of the vectors, then they are able to feed on other vertebrates like us or our horses, and then they transmit the virus. However, you can see that there's no arrow leading from humans or the horses back to the vector or the host, because the level of viremia in humans and other vertebrates do not achieve a level that can be infective to the insect vector. So it ends here. So that's why we say they are dead-end hosts. I hope that is clear. Any other questions? No questions? Okay. So enjoy the rest of the day. Have a good day.
Thank you, doctor. Thank you.